Hello, everyone, and welcome to this episode of the Akkad and Koka Report. I'm Michel Akkad with you in San Francisco, and my co-host Anish Koka joins us from Philadelphia. Our topic today is one of the most important topics in all of healthcare, namely medical education. What are we teaching medical students and trainees in 2018? What's good about the curriculum? What's bad about it? And how can we improve it? We have the great pleasure to have as our guest Dr. Adam Cifu, professor of medicine and award-winning teacher, educator, and author from the University of Chicago Pritzker School of Medicine. Dr. Cifu is a master in the Academy of Distinguished Medical Educators and has been selected as a favorite faculty member by the graduating class of students 14 times. He is the author of Symptom to Diagnosis, a Manual on Diagnostic Reasoning, and co-author with Dr. Vinay Prasad of Ending Medical Reversal, Improving Outcomes, Saving Lives, one of the blockbuster medical books of the last few years. He is beloved by everyone on Twitter, where he generously shares his wisdom. Dr. Cifu, welcome to the show.
Thank you so much for having me. It is a pleasure to be here talking to you guys.
It's great to have you. Dr. Cifu, we're in 2018. What's different? If I went back to medical school, would I recognize what's going on? You know, and to situate you, I graduated in 1993. So, you know, late 80s, early 90s.
Right. That is, I am exactly the same, I don't know, class as you, age of you. And I think, you know, still being in it, it's an interesting question because I think a lot of it is very much the same. Maybe too much of it is very much the same. Though there have been changes a little bit from our side of things, a little bit from how we think medicine should be taught these days, and a little bit because of sort of the changing generation and expectations about what medical education is going to give the students.
Right. So if you were the medical education czar, how would it look like? When you say it's a little bit more influenced on your side, what does that mean? And
Sure. I love it when people say, you know, here, we're going to give you all this power, do what you want. It sort of scares me to hear. So I guess I would start with, I'm a clinician. I'm a general internist. I spend half my time in the clinic or in the hospital taking care of patients. And I feel like where we fail students when we do is that we don't give them enough clinical experience. And when I say that, I don't mean, we're going to get you onto the wards, on day one of medical school to sort of observe things, because I think that's trendy and people talk about that a lot. But I think where we fail students, and we've failed them probably for decades, is that we don't give them enough really guided mentorship on the wards in the clinics with patients. And I think we also don't allow them deliberate practice to begin with, early on. We all think residencies is where you get your, 10,000 hours, do your deliberate practice. But I really believe that should start in medical school. And we don't do that enough. We may even do that less than we used to as physicians have gotten busier on the wards, as documentation demands have gotten higher, that I think to a great extent we leave students, to their own devices a little bit.
I agree with you. Why do you think that is? And I think you're right that it's been long-standing. Where do you trace? Is there a philosophy behind the way the curriculum is set up?
Well, I think it's optimistic to say maybe there's a philosophy behind it. I would suggest that maybe we try to do medical education on the cheap to a great extent, right? We take lots of money from the students, but then if you think about how we educate them, their preclinical work is often in lectures. And there's a bit of a crisis these days with people wondering, boy, why aren't students going to lectures anymore? Why are they staying home and trying to learn this on their own and study for step one on their own? And then we just kind of plug them into the clinical realm as, an assistant, an observer, and we don't really change what's happening in that clinical realm. It's the rare, very wealthy place that lightens up people's schedules in the clinic when they have a student with them, or adds an extra attending to a ward team to specifically teach the student. And so I think it's less philosophy than maybe convenience how we train the students.
Yeah, I think that that's right. Although, I've looked into this a little bit myself.
Yeah.
The structure of the curriculum with, 2 years of classroom and then 2 years of clinical exposure, uh, it appears that it was the model at Hopkins in the early 1900s.
Right.
And that's the one that Flexner, when he issued his report, said, all medical education should be modeled on.
Sure.
And it essentially hasn't changed since then. Now, why? You're at the University of Chicago. Why can't you change things? I mean, if you're in good standing there, you're a little bit critical of the situation. Why does it seem to be so difficult for medical schools to change things?
Right. It's a great question, and I'm gonna move myself off the hot seat a little bit, right? And I'm gonna talk globally. I think you're totally right. I think we're teaching medical students the way we've taught them for 100 years, and and you think about how much medicine has changed in the past 100 years, this might be right, but I think likely it's not right, and at least deserves to be really deeply revisited. I think there's inertia there as well. This is the way we've always done it. And I think there's a lot of fear, right? That especially older, established, well-regarded medical schools, they are competing for a very small group of highly, highly qualified students. And schools are scared to make changes in their curriculum, which may turn off students who are saying, listen, I've done incredibly in college. I'm going to spend a lot of money on this education. Why should I take a risk with University X, who is completely changing their curriculum? And we've had a lot of experience, even with very good, well-regarded places over the last 25 years of curriculum change, which hasn't quite panned out. I think this is an exciting time, sorry to talk over you, because there are so many new medical schools starting out. And I've been impressed with a lot of those schools. Maybe they're not as radical as I'd want them to be, but those schools who are sort of opening de novo and have students who are taking a little bit of a risk going there, being a little bit more creative in what their curricula looks like.
Right. A question I have for you. I had assumed, and I assume, but maybe I'm wrong, that some of the reason for the inertia is regulatory. I mean, in terms of accreditation agencies. To what extent is that correct or incorrect?
Yeah, I would say I think that's probably incorrect. I'm not 100% sure, but I think that a lot of the pressure, at least the pressure I see, comes from sort of GME, graduate medical education expectations, right? I've always, what's happened over certainly the last 20 years as the residency application process and selection process has gotten more and more competitive and more difficult, is that residencies look so much at, say, like USMLE Step 1 scores, right? And this is like, boy, this is how we're going to figure out which are the best students. And so it makes it very difficult for a medical school to change a curriculum where maybe we're going to move our Step 1, we're going to have them take it at a different time, we're going to change the way we prepare them for that exam, because they're worried that, oh my God, our Step 1 scores are going to fall, our students aren't going to match, we're going to look terrible.
Right. And what about from the faculty themselves? The basic science faculty being, having some expectation that, they're going to continue doing what they're doing, that sort of thing.
Yeah, that's interesting. I don't know. I'm going to be sort of, thinking on my feet here. There are certainly basic science faculty who see their teaching role as core to their career, right? And might be threatened with changes to those preclinical courses. I think in reality, a lot of those people, and I think it's not much different from when we trained. Sure, there are the course directors who are very serious about what they do, but there are a lot of people who kind of come in and go out, give a couple lectures, get back to their lab, give a couple of lectures, get back to their clinical work. And if things changed for them, it probably wouldn't matter to those people, right? It's not a big part of their career.
I want to go back to the philosophy, but I'm going to give Anish a chance to chime in here if he has any.
What?
Well, I was going to ask you guys when both of you seem to be suggesting that there needs to be changes to the medical school curriculum.
Yeah.
What both of you? What is the real problem that we're trying to solve here?
That's a great question, right? Why change things? It's been 100 years. We shouldn't just change things because things don't work, right?
Mm-hmm.
I would start out by saying I think we're really inefficient in the way we train doctors, and I'm not one of those people who's saying, "Oh my God, we should shorten medical school." Why the hell do we need 4 years? But I think, and you guys may very well disagree with this, I think we spend our time in the wrong way in medical school. We talk a lot about training students to be lifelong learners. We always say, oh, half of what we teach you now is going to be wrong by the time you finish your training. You hear that again and again and again. But we actually have not shifted the curriculum in a way that we are truly teaching students to be lifelong learners, to get into that habit early on, and to give them the sort of reasoning skills, the kind of the core thinking skills that they really need to be excellent physicians, right? We're still sort of feeding them information, feeding them data that they probably no longer in today's world, when everybody has a connected device in their pocket, they don't need all this time to learn that stuff, Of course they need to learn some. We need to, they need a base, sort of basis of learning to build on. But a lot of that time in the preclinical years, I think, is wasted.
Do you find, is that based on your experiences of recently graduated medical students I guess interns and residents that you're kind of come on, you don't feel like they're prepared, and now
right. And I'm incredibly fortunate, right? I'm at a place, I have the medical students I deal with, I think the world of. We have a very competitive residency, and I think the residents who I work with, I am always impressed. And geez, when I work with them on the wards, they're teaching me much more than I'm teaching them. But I feel like the things that they know well are certainly not what I think is most important. If I ask them, hey, tell me about, HFrEF, boy, they're going to, blow me off the table, right? They're going to know everything, from the newest therapies to the pathophysiology behind it. But, when you put them in a room with someone who's got undiagnosed dyspnea, they often struggle at that. And I would like to see that shifted, that where the skills are is thinking through a patient they haven't seen well, they haven't seen before, and then whatever, going to the literature, going to some sort of source material to say, okay, let me fill in the holes with what I need to know.
All right. Now, that's from a standpoint of efficiency. If you want to, I think if I hear you correctly, you think there should be more emphasis on diagnostic skills or clinical skills in general, that sort of thing. That's sort of labor intensive, right? You need a lot of one-on-one coaching.
Oh, boy, absolutely. So I would pull back a step. I would say, yes, that's very labor intensive. But I also don't think that that's for everybody, right? I mean, there are people who by the time they're, getting halfway through their clinical year, they're pretty sure of what they need to do, right? And if that person is going to be, pulling something out of the air, a urologist, okay, the diagnostic skills for that person are honestly not as important as that person who is going to be, say, to pull something easy, a general internist. And the training should probably pivot at that point and say, boy, what do you, as a urologist who's going to be spending a lot of time in the operating room, a smaller amount of time in the clinic looking at, a more limited range of diagnoses, how do we need to train you at that point? That person probably needs to go back into the anatomy lab, do some really high-level dissection. They need really work with kind of manual training, whether that be with actual patients or cadavers or models, whatever, they need to get that. And that's very different than your student who's either undifferentiated at that point or is going to be a psychiatrist or is going to be a cardiologist.
Sure. Sure, and that would essentially require, a complete overhaul of the structure of the curriculum in
It
a way,
would, right?
right?
It
It
would.
would.
And as you hint at, would be expensive, because I think what I'm looking for is to say, we need kind of core faculty like we have in residencies who would have time to see patients, yes, but probably a little bit of a lighter burden of patients, and work mentoring students. I always pitch one of my colleagues here, Dr. Scott Stern, who's been a wonderful educator for a long time. He was able, with some grant money a couple of years ago, to set up this elective in our medicine clerkship, where he spent entire days with the students. He spent the mornings in an urgent care clinic, seeing patients with them, and they were taking care of the patients. They were billing the patients. They were doing everything. They would then have a little bit of a debrief where they'd say, okay, what are the unanswered questions with these patients? What do we not know? The students would go off. They would, probably have lunch, but also read, look things up, learn, educate themselves for 2 to 4 hours. And then the entire group would reconvene in the afternoon, and they'd say, okay, this is the patient. What have we learned from the lab tests, the radiology, the evaluation that's come back since we saw them? And what should we do? And they'd argue about it because, as you guys, know certainly as well as I do, that a lot of times the decision-making is not clear. And what you read in Up to Date or what you read in the New England Journal is not the answer, right? You got to think about who is this person and what's the specific issue that they have.
Right. I think, and I may, upset a lot of my friends and colleagues with what I'm saying here, but you hinted at a bifurcation between maybe proceduralist, technician type activities.
That's your word, not my word.
Right, I say that as an interventional cardiologist. So I can say this because but I think it's a real distinction. I think it's a real distinction between somebody who's going to fix something and doesn't necessarily need to take the long view on things for the patient, versus somebody who, on the contrary, is going to be with the patient all along, and perhaps establish a long-term relationship and that sort of thing. And so to go back to the philosophy, because if you read Flexner and his report and the thinking around that time, there was the problem to me has to do with what is the essence of medicine? What is it that we're trying to teach?
Yeah.
And at that time, Flexner's idea was that really medicine is the application of science. I mean, there was a huge the spirit of the time was extremely hopeful that if you had a lot of technical know-how, that then you would apply the technical know-how to the patient.
Yes.
And then everything would be fine.
Right.
But I disagree with that approach because we're not machines. Patients are not machines. They are machines in some aspects. So certainly in some, in certain aspects, we are machines, and we want technicians and we want proceduralists to fix the part that is broken. But we're also not machines. We're also very, we're human beings. Very complex. We perdure over time, despite the body failing and the machine breaking down. We still continue, and there's an aspect of medicine that recognizes that. And there's an aspect of doctoring that takes that into account and has a longer view, a broader view. And so my beef with the curriculum is that it's adopted the Flexner's approach and emphasizes a sort of a technical, analytical dimension to everything, with a lot of data to fill our brains with a lot of facts and whatnot. And licensing is predicated on this idea as well, because Flexner and
absolutely
Flexner, report and licensing. So now, if we're going to change the curriculum, dramatically, then it's our hands are tied because of the licensing expectations. How do we determine? So that's those are my comments. So, if medicine, should we bifurcate? Should we even? If we had our dream, if we could even control the licensing process, should we even think through and bifurcate earlier and have physicians versus surgeons? You know, the old dichotomy that existed since Hippocrates in a way.
Yeah.
Hippocrates mentions this dichotomy between the physician and the surgeon.
Yeah, let me push back a little bit
all right.
because so on the one hand, just to comment, which I think your discussion of sort of Flexner and where it brought us is right on, and the optimism of the Flexner report has always seemed sort of ironic to me when you think that he's writing at a time that medical knowledge was minimal, from our standpoint at this time. And it's sort of charming that like, oh, we're going to fix everything because we know so much, which is ridiculous. It's kind of ridiculous now, and it was certainly ridiculous 100 years ago. As far as the bifurcation, I think, and don't let me put words into your mouth, I'm sure you won't, but I'd probably be a little bit less extreme because I am certainly a generalist. And I live my life getting annoyed when I get patients referred back to me because they complain to, I'll put it in your camp, the cardiologist about the cough they had. And the cardiologist is like, cough, they don't have heart failure, they're going back to their internist. And I was like, God damn it, excuse me, you are a doctor, at least think about that a little bit. But I really do think that today, when I ask for more clinical training, and what we haven't really talked about, though we've alluded to, when I really think people need less basic science training, I think that the later years in medical school, after people have gone through, fairly traditional clerkships, so everybody knows what it's like to deliver a baby, everybody knows what, basic pediatric health is all about, that then we should use our later years of medical school to really start training people in their specialty. And I'm sort of fine with that because I think there is so much to learn that if people get into their residencies with some really improved basic knowledge of what their field is going to be, we can only benefit from that.
Right. I think your approach or your proposal is certainly much more realistic than mine. But I must say that when I do, there's no real reason for the work that I do as an interventional cardiologist. When I do that work, there's no real reason that work could not be done by somebody who has not gone to medical school in certain ways. Provided he or she would be under the direction of a physician. Right. But the technical aspects of putting catheters in the heart and blowing up balloons and cracking plaques and whatnot, it's purely technical. And, I enjoy it. I don't mind doing it and so forth. But at the same time, I think it's it could be opened up to a lot of people who, that would bring in a lot of competition, that would decrease the cost of things, if technicians, just did that. And I don't see any fundamental reason why it couldn't be done by technicians.
No, I'm okay with that. And I'm not like, I'll bring it to baseball and I would say, I'm not a representative of the players union in the American League who's like, we can't get rid of the DH because we're going to lose jobs. I'm sort of fine losing jobs. If we truly are going to have a doctor shortage, this is fine. And there are models for this, right? I think anesthesia is probably, way ahead of everybody else. That a while ago we said, listen, simple cases, you don't need a doctor to do that. A really well-trained nurse anesthetist can do it with a doctor, looking over 4 different rooms. Okay.
Right.
We've done it somewhat in critical care, right? Where we've moved a lot of critical care physicians to central locations who monitor people remotely. That's a little bit what you're talking about. And I think, you understand what you do obviously much more than I do, but probably as an interventionalist, wow, yes, you could take people, just train them how to do the interventional stuff with you as backup for complications or when real medical decisions arise because of complications on individual patients that's not directly related to, boy, how am I going to get to that occlusion?
Right, correct, and not just as backup, but really as director. So in that case, I would see if you're going to use the dichotomy and use the term physician versus surgeon, or so the physician would be on top,
Yeah.
and running the show, because that person, that doctor, would assume the ultimate responsibility, right, and therefore would direct the work of. Now, of course, you have to delegate if you're a physician and you don't know how to do the procedure. You have to delegate some decision making. To the proceduralist, but still it would be overall your responsibility for the care of the patient. And so
Right.
the decision to intervene or not intervene, that sort of thing, you can delegate, and you delegate as much as you think you should based on whoever is you've hired as a proceduralist, or whatever proceduralist, whatever their experience is, whatever their judgments you believe
Yeah.
to be, and that sort of thing.
Yeah, it brings.
Yeah.
I mean, it's cool to think about, right? Because it brings
Right,
up
but it's
so
completely
many.
right.
'Cause
Completely unrealistic. Yeah.
well, maybe not.
Yeah.
On the one hand, we have to train people very differently because, as you said, that delegation, that responsibility for patients who you're not directly caring for is tough, right? That's a whole nother set of skills you have to learn. And also, it actually, I think, makes the physician's job harder, right? I think of what I do as a general internist, and um, maybe a quarter of the time with patients is really hard, high level thinking for me. Okay. And 3/4 of it, I completely acknowledge that you could probably train people in a year to do that stuff, doing healthcare maintenance, talking to people about how to treat their BPH is mindless to me at this point. Um, but so if my entire career was the 1/4 of the difficult stuff I had, boy, those would be hard days. I often leave clinic feeling like, geez, I've made too many decisions today. I can't make one more. I would burn out in that day a whole lot faster if that's all I was doing.
So you allude to a point that I was going to bring up, listening
Yeah.
to the two of you, destroy the future of doctors.
Right. Half the people would quit after this conversation. Like, I'm not doing that.
We're gonna get hate mail, I'm sure.
I mean,
You'll
one
get
of the
the
most.
hate mail. I won't get.
I think it's little known that one of the things that one of the most significant pieces of legislation that is really we're seeing now change the landscape of healthcare was something a law that Bill Clinton signed, the Balanced Budget Act of 1997, and that little act allowed for direct reimbursement by Medicare to nurse practitioners.
Right.
And there was relatively slow uptake early on. I think, but of course now, you walk into intensive care units, you walk into any hospital, and you have, they're flooded by physician extenders or nurse practitioners or whatnot. And so, kind of the future that you're seeing or that you're talking about in terms of, compartmentalizing. So
Right.
a lot of the stuff that is not, I guess, physician worthy,
Right.
is done, can be done by other folks. But
let me just cut in
Yeah.
to say, so I think that's an amazing point. It is absolutely true. And I think if done wisely, it's terrific. It is unfortunately not always being done in a rational way because there are times, and I will say at my own institution, that I have referred people for a consultation with a cardiologist or a pulmonologist, and I get back a note from an advanced practice nurse about that patient. And as you've heard me talk, man, I am absolutely happy with deferring lots of what we do to people trained differently. And this will probably sound snooty, but as a practicing internist who's been doing this for whatever 20, 25 years, when I ask for a consultation, I sort of hope that I'm getting it from someone who knows a whole lot more than me and is trained a whole lot more than me. And we don't always, I don't know, kind of titrate that correctly, I think, right now.
Yeah. So, and this is exactly the point I was going to bring up, right? That we started out this conversation talking about medical school and education and some of the gaps that you see in terms of, the clinical expertise and other things that we may get to. But yet you have, yet none of these problems seem to be facing the world of nurse practitioners. Like how does it, how does it, what is a nurse practitioner's training? What is a nurse practitioner's clinical training?
Yeah.
And yet we have flooded our clinical areas with they're in urgent care, they're in intensive care units, they're advanced practice nurse care, they're heart failure. Consultations are now being staffed by NP. So, it's somewhat ironic that we are talking about the deficiencies of medical students when we have medical students that have 4 years of dedicated time that they spend doing, nothing but accruing debt and being taught by some faculty or the other. And then after that, we have residencies, which again, they're spending full time, right? Yep. Compare that to what some of these other folks are doing. So, I'm not with you folks on some of this, because I think the less you know, the less you understand what's in your scope or not. Does that make sense? Meaning,
absolutely.
Meaning, I think you understand very well what it is within your job that can be done by someone with lesser training. Michel understands very acutely what parts of his procedure can be done by some trained person, some trained non-physician. But I think both of you are taking for granted the massive amount of knowledge that you've through experience and also by the way, the two of you are highly filtered, meaning you guys just didn't become physicians because you wanted to be physicians. You became physicians after going through a relatively arduous process to get to where you are. Michel. I think one of the things, and beyond that, one of the things that I find wrong with medicine today is the fact that we have such a massive amount of compartmentalization that takes place. So we have this crazy system now where the general cardiologist can't interrogate a device, or the general and the interventional cardiologist can't do a TE. And only now, and I think when you don't have a certain breadth of foundational knowledge in whatever you're talking about, you come to that realization later on. For instance, I was talking to Jake Kirtane, who's one of the leading clinical trialists, interventional cardiologists. I was talking to him about the path that he took to get to where he was, and one of the things he regrets now, given all these advanced interventional procedures that are being done endovascularly, is that he didn't spend any time doing TE, so he doesn't really know how to do TE, or he hasn't. So we have to be. I think we need to have some. We probably need to be a little bit careful about how we try to move.
Right.
But no, I'd love to hear from you guys.
So I agree with you. My response to this would be that you're absolutely right, Anish. And the problem now is that there's not only a sort of a compartmentalization or an increasing compartmentalization and fragmentation of how the care is delivered, but there's also, and there has always been for a long time, a fragmentation of accountability. And again, and I go back to this model, the Flexner model, where the human being is a machine, and you're going to have the different specialists working on different parts and analyzing, and that our system is predicated on that model and allows for a fragmentation of accountability, so that there's no one that's fully in charge, right? No one fully accountable. If you send to a specialist, and then, and it's very helpful to cover our own behinds, right? To have this fragmentation of accountability, dispersed throughout the system. In my ideal world, there would be someone, and it doesn't have to be a single person. It can be a person, but it could also be an institution, right? It could be a medical institution, a healthcare institution, taking on the full accountability and the full responsibility, you know. And then within the umbrella of that accountability, then you can break up, you know, you can fragment and you can specialize and you can train people to different skill sets and whatnot. But they would have to be one accountability, you know, that right now is nowhere to be seen in healthcare.
I got to push back on that
All right.
and I can't believe you're saying it of all people.
Okay.
The institutional response.
Are you going to also, you know, do the face palming? You're going to send an emoji on Twitter with?
I can't do that in real life.
Right.
So, and it's interesting. I think this comes from a little bit, you know, what we all do, right? On the one hand, Anish, I think you're right, and you're pointing out, you know, really a huge complication for this, because yes, it's okay to disperse responsibility a little bit, and we really want the people who are doing certain things to be great at that. And if what it takes to be great at that means only doing one thing, you know, so be it. And I also agree that, you know, we need responsibility over, you know, an entire patient's care. But I sort of see that as boy, the ultimate kind of physician task, right? That's what I do. I get annoyed as a general internist when people call me to review tests that were ordered by other people, right? But even though I get annoyed by it, that's my job, you know? I need to be looking out for all these things, because I'm going to refer to, I don't know, a you know, hematologist to look at this person's thrombocytopenia that I don't understand. They're going to order, I don't know, let's say a CT scan to look for, you know, lymphoma, and something else turns up on that. And I need to be looking over to figure that out. And so I think that expertise, broad expertise, is key, but I think that's key in a subset of people. And I think other people are perfectly reasonable, capable, competent of peeling off little bits of what needs to be done, if that's what they're interested in, if that's what they're kind of gifted at, as long as we have the kind of traditional physician in the background who's been trained with this ridiculous 12 years of training.
So in what way is that pushing back against what I was saying?
Well, it was just the institutional responsibility.
Yeah, but what does that mean?
No, right. Well, I'll tell you what that means.
Yeah, how is the institution? What institution are you going to hold responsible? You're going to hold the university, the training institution responsible for the failings of the.
No, I mean, I take, to me, the greatest example, and I did some research. My proudest little blog article is an article that I did on the history of the Mayo Clinic pre-Flexner.
Wow.
And I went to source documents, because they actually, in the 1920s, the Mayo published its own history, you know, from the 1870s up to the 1910s, 1920s. And the Mayo Clinic, to me, is really the model, because it took on responsibility. You know, there was no licensing, there was no, but if you went to the Mayo Clinic, so the Mayo Clinic hired a bunch of doctors. They specialized. They had a lot of. They invented specialization. Really, in the U.S., they introduced it. They had a radiology department. They had a pathology department. All of this was brand new, and it came on at that time. So, but ultimately, the responsibility was to the Mayo Clinic and its name and reputation, right? So it had a commitment to the patient, and then they could parse out how much fragmentation, you know, how much specialization. And if they failed, then, you know, maybe another clinic down, you know, which it was being modeled, it was being duplicated. The Cleveland Clinic was essentially an attempt to duplicate what the Mayo did. But by that time, by the 1930s, you know, licensing had taken place and the landscape had changed. But pre-licensing, I think that was the right model. You know, so the institution like that, yes, taking on responsibility, and then maybe delegating some of that responsibility to Dr. Cifu, who's going to be a general internist, who's going to really be in charge and be the boss and control really what the proceduralists do and so forth. And you give them some slack, and if they don't do, you know, perfectly the way you want it, you give them some slack until you decide that you can't give them slack anymore, and you replace them, that sort of thing. So that's the kind of accountability that I think needs to be there and can be institutionalized in a very good way. but it's not anymore, and it's not, and it requires a sort of an overhaul, not just of medical education, but the whole system, and deeper societal expectations, if I
Sure.
may say.
I guess maybe I was. It's interesting when I hear you talk it through like that. I'm sort of okay with it.
Yeah,
My
see, I'm not so radical.
my objection is that living in the real world and knowing how institutions behave, Mayo Clinic included, patient welfare, I'm not sure is always the most important thing.
Correct, because ultimately, I think the problem right now is that the institutions are not accountable. So legally and culturally, we seem to be okay with fragmenting accountability, and the patients are really suffering a lot from that.
So to take it back to medical education, the medical education, and some of the deficiencies that perhaps exist. We're talking about.
I can't even remember that we were talking about medical education.
Right. So we're talking about, and this touches on institutional failures, correct? One of the common themes, and one of the things that I bring up every chance I get, is the fact that if the health system fails, or if there are things that are, as we're saying, not being done with the patient at the center, right? That is only happening because there are physicians that are complicit in that, correct? So why Michel, the libertarian, wants to take the onus off of the individual physician and institution.
Ouch.
But why? But I don't. Why are we not holding our? I mean, that's the problem I see in terms of whatever our education system is now, and it's getting worse and worse. And that more and more physicians are aligning themselves with incentives of the health systems, and a lot of times that doesn't go along. That isn't patient centered. So, we can talk about more clinical experience, and but don't both of you find that that's something that's fundamental, that's wrong? Is that not make the top three in terms of why it is that we seem to go along? A lot of us seem to go along lemming-like with the most recent guideline that will say that, hey, if your LDL is over 70, is 75 and you're high risk, that, hey, that's a class 2A recommendation to start a PCSK9 inhibitor. Never mind that, it's, whatever the number needed to treat, or the absolute risk reduction for somebody with an LDL of 75 and putting them on a PCSK9 is, God knows what. And never mind that a PCSK9 inhibitor, even with a 60% cut, is going to be $12,000 a year, or
right.
And these numbers I'm making up, but somewhat. But don't you find, that seems to be a large problem, right? How do we address, or if you agree with that, Adam, and Michel, how do we address that?
Well, so I'm not sure it's as much of a problem as you're laying out, and
Okay.
I agree that I think that if that was truly the world, boy, I would be terrified. And maybe I'm just living in some fairy tale land, that I think most of the people who were churning out of the residencies I know, the fellowships I know, are there's a lot of those people who are really deeply dedicated to patient care. And I think actually proof to this, and maybe this is a strange proof that you'll disagree with, but the I don't know what you want to call it, the sort of concierge health movement. I can't keep track of the names, that they keep changing it to make it not sound like concierge medicine. But those people are sort of doing it for that reason. They're saying, I want to be responsible for a group of patients myself. I want to be able to spend time with those patients. Yeah, they probably want to make a little bit more money doing it as well. But it's interesting that at the same time that maybe there are pressures to become more diversified, there's also this subset of people who say, wow, this is wrong. I want responsibility. I want to feel like I'm deeply attached to this patient.
But that's a really small minority of folks like Michel, who have the cojones and whatnot to be able to do direct primary care and exit from the system and stuff. But but are we not graduating, Adam? Do you not find that we're graduating a lot of guideline bots? Meaning, folks that, and again, and it's not their fault. It's like institutionally, don't we put a tremendous amount of faith in guidelines that are that are at times very dichotomous. I think, I like the example I gave you. I mean,
right. No, I'm with you. And listen,
yeah.
As you know, I spend a lot of time evaluating guidelines
Right.
for our series in JAMA, and so I am well aware of the shortcomings of guidelines.
Right.
I am also well aware of the shortcomings of medical practice, and knowing that a lot of people who are very busy need some guidance. I do spend, I think, if I were to think about, so in my role as an educator, what do I spend my time doing?
Mm-hmm.
Man, I spend my time trying to teach people to, figure out how to read the literature and how to question those guidelines, because you probably agree, there's a lot that's right in all those guidelines. There's some that's wrong. And then the problem is that when you take one of those guidelines, some 400-page, hypertension guideline, and try to apply that to an individual patient, that is really, really, really difficult.
Right.
And so I agree with you there. And I think when I talk about what medical education should shift to, and I talk about, shifting away from, the months of physiology, part of what I'm shifting it to is the intelligence to say, look, I know how to see a patient. I know how to get the important information from the patient. I know how to frame the decision. And I know how to go to the literature. Maybe that does include a guideline, but it also takes into account a lot of knowledge of how to question that guideline and how to apply the actual evidence correctly, if you can, in that patient. Because as you guys have, argued, I think, intelligently in the past, of course, with clinical experience, you're going to have to say, look, sometimes we got to go away from the evidence, because that's what doctors are supposed to do.
I'm absolutely in agreement with you, Adam. And let me go back to what Anish was saying. And you're correct, Anish, that in a way there's institutional, it's beyond guidelines. We're also are training students to have a bit of a shift work mentality. It's the system, that sort of thing, and have less attachment to the patient. So they're much less patient-centeredness. And I go back to sort of accountability and that sort of thing. But to go back to the philosophy, the sin of Flexner, if I may call it, of considering the human being as sort of a machine that needs technical expertise, and that's the essence of medicine is to apply scientific knowledge to that machine. I think we need to, at the end of the day, we have to recognize that medicine is primarily, so first and foremost, it's an ethical commitment to the patient. And then the scientific expertise is secondary to that ethical commitment, right? So if you're ethically committed to the patient, then most of the time, perhaps not all the time, but most of the time, then you're going to go and obtain the scientific knowledge and pursue it and research it and improve it and then apply it as judiciously and so forth. And then you will have the Adam Cifu School of Medicine, an institution that professes this commitment, right? And professes this commitment, and then it explicitly says, well, this is what we believe. We believe that biological science is important, and clinical trials are important, and EBM, and blah blah blah, and that's great. And you cannot license that. You cannot license an ethical commitment, right? An ethical commitment is something that one has to profess. And right now, there's lip service paid to the ethical commitment, but the license gets it granted to doctors on the basis of technical expertise and passing tests and whatnot, and that's that to me is the issue.
Michelle, let me just ask you: do you think that ethical commitment needs to be taught?
It can be. It can. Does it need to be taught? Yes, in a way, it does. It needs to be. It needs to be articulated and made. That's what the Hippocratic school did, right? It articulated an ethical commitment, and then you're going to say, I'm going to, throughout my career, I'm going to abide by this ethical commitment that I've made. And if I stop believing in that ethical commitment, then I will change school, if you will. I'll belong to something else.
Yeah.
And I'll try to make it explicit, right? But
Yeah.
but it's this profession. The word profession is. We had an episode on with a philosopher on the Hippocratic Oath. Professing is essentially articulating what we believe in. So that, to me, that's what medicine is. It's an ethical profession. And then secondarily, you can say, well, beyond that ethical profession, I'm going to, I believe that scientific knowledge is extremely helpful and blah, blah, blah. And fine. And that really you cannot license, which means that you have to accept that there may be somebody else making a similar ethical commitment, saying, well, I believe that astrology is really what is going to guide my my treatment of patients, and so be it, and let the chips fall where they may. And if you let that happen, that you will see that for the most part, the scientific school will gain, right? Will compete, and the astrology school will not do so well, because that's the history and the pre-Flexner environment. If you study it, the Mayo Clinic did very well. They were competing against the homeopath, believe it or not, in Rochester in the 1800s, and the homeopaths were the intelligentsias at the time before the Mayo Clinic was established. They were where the elites were going. Then once Mayo started his thing, he was able to get all the business out of the homeopath. Not completely, because always people will prefer, will like astrology and they will like this and that, and there's no way you can stamp that out. It's in human nature. But that would be my sort of reform of medical education, is to articulate first of all what the essence of medicine is.
Michel will not rest until licensing must go.
Yes. I got it.
But do you find that that this ethic, the ethical commitment to patients, it is an unwritten one that has been made by physicians, by the corner store, by the physician in the community, for so long, correct? The guy who puts a shingle out, and
right.
He's your doctor. You walk over, you see him at church.
Right.
If you have a cold, you give him, you call up his house.
Right.
Sometimes he comes over. And I think that what we're not talking about, we talk around, we beat around the bush, is the fact that when we destroyed that person, because that person rarely exists now, we now have this maze of, if you call the covering physician,
yeah.
Says go to the ER, and
yeah.
I mean, you all know what I'm talking about. We have somewhat abandoned, as a profession, we have abandoned our commitment to patients because it's better for our lives. And I don't know, and I think, I don't know how that happened or how we kind of allowed it to happen. I know it's easier for us. Like if I were to if I was to become employed by a group, right now I'm on call for, 3,000 patients or something like that all the time. I'm solo, and
yeah.
Every call comes to me, and Michel is the same way, I'm sure. And but once one of the big attractive things about joining a large group is that my phone is now off to you for 30 or whatever 25 days of the month. Is that, do you think that's an issue, Adam, in terms of, is that something that have we abandoned our patients somewhat? Have we worsened patient care by doing that?
So I would say, and I'm going to answer this in two ways. So I don't think we have, because I don't think that the overwhelming majority of people, the overwhelming majority of the time, need that, right? The people who need that are a small set, and usually for a small amount of time in their life. And we do have to train, and I like Michel's talk about, training the values. We do have to train all of our physicians, whether they're, an interventional cardiologist or a general internist or a pediatrician, to understand when patients need what you're describing, which seems, wonderful. And that's the time in people's lives that you have to say, wow, I don't give my cell phone to all my patients, but during this period of this person's life, this person needs to be able to contact me and not go through, everybody else. why I asked about the training of values is I was kind of reflecting on myself. And yeah, of course, I recited the Hippocratic Oath. I get it. But what drove me early in my career, was mostly fear, right? I don't want to screw up. I'm going to get sued. Horrible things are going to happen. And interestingly, and Anish, maybe it goes to what you're saying, is that it was later in my career, right? It was once they were my patients and it was my practice that I began to feel really, truly, personally committed to those patients. And I'm not sure we can teach that. I think that's an experiential thing. And maybe it goes back to that has to happen earlier. It should have happened earlier with me in medical school, in residency. So I developed that.
Yeah, and that goes back to what you were saying. I think if you had your way with the medical curriculum, I think you would introduce some of that right from the get-go.
But it
Adam
would
was,
be resisted. But it would be resisted by the physician community, don't you think?
That's a good question.
Meaning the overarching.
I get it.
Hospitalists, ER. I mean, we are training
right
shift workers. We are not training.
Right, and
we're training proceduralists who spend 4 hours doing, or 2 hours doing an AFib ablation, and then back off to someone else, right?
And listen, I don't know why this comes to mind for me, but I think proof of that is think about virtual colonoscopy, right? Perfectly good procedure, probably somewhat easier for patients than real colonoscopy. But if you were going to adopt that, what you needed to do is you needed to have a whole bunch of patients getting scanned in the morning and gastroenterologists sort of sitting around in the afternoon to get anybody who needed a colonoscopy that day. And that's a hassle for us. That makes gastroenterologists' life worse. And I think that's why that procedure has not gone any further. So I absolutely agree with you that that's a hurdle to overcome. But I think the majority of people who go into medicine, and maybe this is a little bit too optimistic, are truly dedicated to patient care. And if we can build a career, a life where that doesn't seem overwhelmingly burdensome, I think it's too much to ask for, hey, listen, you're on call for 3,000 people who are going to utilize you a lot every single night, so you can never get through the night. That's not a life any of us would choose, and you'd quit, in a month, and you'd work at, I don't know, you'd become a barista or something. But we can build things where, look, you can take incredibly dedicated, ethical care of your patients in a way that's humane.
On that note, optimistic note, and I agree with you, Adam. I think we need to continue to push and have the conversation and change the culture as you're doing. And Anish wants to have the last word.
No,
I'm looking at the clock, and we're going to stop shortly.
No, five more minutes. 5 more minutes. I'm sorry. We started 5 minutes, about 5 minutes late. But,
I thought I was going to have to argue with you guys more, and you've been much too nice to me. So, Anish, you need to come up with something.
I'm trying. So here, my final push. So I saw a tweet of yours, a tweet of yours, where you give out your book. The medical reversals to all. Is that true? You give out the book to all the incoming?
That is. I only have to pay 40% of it. I don't get any money back from obviously what I've paid, and because I've made it part of the curriculum, I do use some of my educational funds to do that. It's part of. I'm going to defend my. Go ask your question.
So what how have you made that part of your curriculum, and what are you hoping to what are your goals in terms of what you want the medical students to learn with that book? And
so I teach a course in the first year, required course for everybody, called Medical Evidence, and it is it's probably it's what the courses that we all took, that was biostatistics and epidemiology and that kind of stuff. It's what that has evolved into. Probably appropriately evolved into, given the kind of students we try to train. And interestingly, I mean, I worry about people's medical decision-making being based strictly on what they read on UpToDate. And I'm a big UpToDate fan, but I want people to be making their own decisions. And the reason that Vinay and I, spent a lot of time writing a book is that we feel pretty strongly that a lot of times people's decision making comes from the wrong place. Okay, and we chose to say where the right place is, at least when we can do it, is from well done, randomized controlled trials. Now, obviously, it's not every decision you're going to make. And so I want my students to leave thinking that, listen, you need to question what you're told, how you should manage patients. And when you can, you should be making those decisions for yourself based on a really intelligent review of the evidence.
Is there any counterpoint to this brainwashing that you're doing?
Absolutely not. It's my course. No.
I'm just making light, but meaning, is there? Do you think that? Do you think that there's any debate about? I mean, I'm trying to get at the idea that there may be some. I mean, the RCT, what we say all the time, RCT is the end all be all, and I know you know that as well, and you're a clinician and whatnot. But is there something discussed that's reflective of the debate, or do you think that's valuable, or do you think at that level that, look, you need to know that
right,
you can't just rest on bioplausibility and
through
all the different ways that we reverse things and whatnot.
Right. So I I actually do include quite a number of readings, going back to Alan Feinstein and beyond, of sort of, hey, when people really question evidence-based medicine, where do those questions come from? I'm honestly sort of, and you probably get this from the way I talk and the way I tweet, is that I'm a bit of a fundamentalist in my moderation. I don't really trust anybody who's too dogmatic about anything. And I can't understand where people are coming from when they're completely disregarding evidence. I also can't understand where people are coming from when they're actually managing an individual and there's no evidence to guide your therapy, and they say, I can't do anything here, and that's ridiculous. And I think the problem is, and I think we're all at fault to this, is we like to take strong positions, we like to sort of develop straw men which we attack, but I think any of us who actually practice medicine recognize that, look, it's not a perfect science. There is a lot of art to it. But I have trouble with people arguing with me who don't rank things maybe in importance as I do.
Anish, I'm going to block you here. I'm going to block you because this is a very important conversation, but I want people to read people who have not yet read Ending Medical Reversal to read it. And then we'll bring you back, Adam, and Anish can have his fill of asking you questions and trying to challenge you on your ideas. This is too important to just leave it at the end of the show.
No. I know. I'll just say that we're talking about medical school education I'll just say that what I understood very late, too late, and was that epistemology is something that is so deep, and I as a whatever intern and resident and first year out, I just thought the truth was regurgitating what the New England Journal said. And cardiology is full of 9,000 patient RCTs.
Sure.
If there was a question, the answer was provided here. And it took me a while to get to Michelle's level of understanding in terms of how we try to move about to the truth, and the history of medicine, for instance, right? Like, if I hadn't had a child and gone through some stuff, I don't think I would have at all an appreciation for the history of medicine, how it is we got from point A to point B and stuff. And
I got to say, I have a talk. It's actually the last talk in the course by James Woodruff, one of our associate deans here, on uncertainty in medicine, which is basically philosophy of knowledge more than anything about medicine. And I am sure that most of the students are sitting there being like, what the hell is this all about? But it's crucial because, you know, there is little truth in medicine. There's little truth in life, and it applies to medicine. But we have to make decisions, and it's why I love the field. I love it's what we do. But as you say, I mean, boy, it's a tough nut to crack.
Right. Is that talk on YouTube, Adam?
You know, it's not.
Okay.
It's one of our lectures. I wonder if I can post it. It's a wonderful talk.
I want to link it. I want to. I'm cutting off Anish because I know we'll have you back. I know we'll have you back, Adam. Your Twitter handle
is just at Adam Cifu, ADAMCIFU.
And we'll have all the links to your book, to your webpage. Adam, it's been wonderful, absolutely wonderful conversation. I think we, you know, despite our disagreement on Twitters, I think we're, you know, quite a bit closer than people might think. And even on Twitter, our disagreements are always, you know, good-hearted and
absolutely.
And I'm sure I really want to have you back at some point to explore other issues of interest. You know, we started off talking about the medical education in 2018. It's really the state of medicine in 2018 that we've covered, and that was wonderful. And I'm sure the audience will appreciate it.
Yeah, it's a pleasure talking to you guys. Thank you for having me.
Okay, thank you.